Welcome to Skeptics in the Pub Online. My name is Kat and I'll be your host for the evening. If this is your first time joining us, Skeptics in the Pub Online is a coalition of skeptics from across the UK and Europe. We came together to host online talks in April 2020 when we couldn't meet in pubs. But we liked what we were doing so much, we decided to keep hosting events online even when we were allowed back out in the wild. As you know, the last ever QED is happening in October. Now, tickets are already sold out, but we at Skeptics in the Pub Online are still able to offer a couple of tickets through the QED Attendance Fund. So if you couldn't afford tickets, please apply through our website at sitp.online, or if you can afford to, please donate to the QED Attendance Fund to help us cover the cost of tickets and accommodation. Links for tickets or to donate money will be made available in the chat bar throughout the night. So tonight, the format is, as ever, we will have a talk from our wonderful guest speaker, after which we'll have about a 15-minute break. After the break, we'll come back for a question and answer session. If you'd like to submit questions for our speaker, you can do that by going to sitp.online/ask. The links for that will be made available through the chat. And even if you don't have questions yourself, you can go on there and upvote questions you'd like to see asked. Our speaker tonight is Dr. Anna Fieldwalker. She's a postdoc researcher at the Great Ormond Street Hospital, working on pain management programs for young people with all kinds of chronic pain. So please fill the chat with applause emojis and welcome to the screen, Dr. Anna Fieldwalker.
Hi, everyone. Thanks for having me. So as Kat mentioned, I'm going to talk a bit about what chronic pain is, why we should care about it, and how it is currently treated at places like GOSH, Great Ormond Street Hospital. Then I'll move on to describing some emerging treatment approaches, including our new pain management program. Just a heads up that unfortunately I can't present any of our unpublished data today, but if anyone is interested in knowing more, please let me know and we can get in touch. So, as Kat mentioned, I'm Anna Fieldwalker. I'm a psychology postdoc researcher with a particular focus on pain in children and young people. I'm especially interested in how we can make changes earlier on in life in terms of mitigating chronic pain. So last year, I joined Great Ormond Street Hospital and the UCL Institute of Child Health to set up a really exciting research program on improving quality of life for children and young people with complex chronic pain. The reason I'm so excited to be finally working in the pain research field is because it really pisses me off. I remember sitting in an undergrad psychology lecture with my friend, and she said that the best advice she'd gotten for choosing a research topic or even a whole career was to pick something that makes you angry. It didn't really make sense to me at the time because I was like, well, the psychopharmacology of selective serotonin reuptake inhibitors sure is interesting, but I'm not really getting mad about it. But, whatever, you do you. And then a year or so later, I did a university exchange to Canada where they do a lot of pain research. And I randomly picked a course on the psychology of pain, which sounded interesting. And at that point, a few of my friends had developed chronic pain. In the first lecture, I was totally hooked. And in the second lecture, I remember the professor talking about how pain is the number one reason that people go to the doctor. But out of the many, many years of medical training in America, only about 9 hours of that teaching is on pain. This kind of started to explain the terrible experience that my chronic pain friends were having. No one understood them and no one was taking them seriously, and they were just getting gabapentin chucked at them, resulting in all kinds of awful side effects. So I sat in that lecture theatre just raging. And that anger is why I'm here today. And I want to get you a little bit angry about it too, but I also want to make you all feel really hopeful about where it's going. So I'll start off with defining what we mean by pain and chronic pain. So, pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I'm going to be banging on about that for the rest of the presentation, basically. But the crucial idea here is that pain is not simply a physical phenomenon. Before we go into this, a simple explanation of the pain perception pathway. So, in red, we can see the ascending pain pathway. So, for example, we have a pain stimulus in the body. So, for example, like say you're getting your first tattoo soon and decided to test what it feels like to get a needle poked into your skin. So you, I don't know, poke a needle into your finger. And this activates pain receptor cells that we call nociceptors, which send a signal through the spinal cord up to the brain, which then goes out to cortical sites. So different areas all over the brain process this pain information, and we feel pain. But I also want to point out this blue line, this blue pathway going downward. So there are multiple descending factors, including cognitive and emotional factors that can heavily influence the amount of pain that we feel. This is how, or can be how, acute or short term pain works. Usually, for example, when we have an injury, the pain will go away with the injury healing. However, sometimes it can go wrong and we can get pain that persists. When we talk about chronic pain, we mean pain that persists or recurs for 3 months or longer. Quite often, chronic pain can just start happening for no discernible physical reason. For anyone over the age of 30, you know that chronic pain is not a rare phenomenon in adults. It is the number one reason why people seek out healthcare, and it affects an estimated fifth of the worldwide population. And the prevalence is quite similar in young people as well. So in the UK, almost 18% of teenagers report chronic pain at multiple body sites, with a similar prevalence across Europe and North America as well. And around 5 or 6% of young people report that this pain is moderate to severe. Um, so why is chronic pain a problem? Surprising no one, chronic pain is associated with decreased quality of life and increased healthcare use. There are quite a few risk factors for chronic pain, but I've picked out just a few examples here to show how many different factors can all play a part in pain chronicity. So, for example, young people assigned female at birth are more likely to experience chronic pain, and gender can influence pain experience too. So, for example, gender-based beliefs around pain. So, for example, if the belief that men are more stoic and women are more expressive, that belief can affect pain threshold and tolerance levels. So, for example, stereotypical masculine beliefs can reduce pain expression. Lower socioeconomic status associates with higher pain prevalence, and as do early childhood experiences, or ACEs, as you may have heard them referred to. And this is from a really great paper if you're interested in how sex and gender influence health outcomes, particularly pain. I really recommend Caitlin Boner's work. She's been doing some really interesting work in Vancouver around sex and gender, as well as neurodiversity and how these factors interact with pain, especially chronic pain. But with this slide, I just wanted to highlight how throughout the life experience, there are so many factors going on that interact with each other. Some things get more important than others as time goes on, but there's really no hard stop point for any particular influence. This is just another really cool graph depicting the impact of sex and gender on health, but this is really relevant for pain as well. Just wanted to point out that the environmental and social factors are relevant right from conception. So, for example, maternal nutrition. And the social factors continue to influence the risk for chronic pain or other health outcomes throughout life, and they influence biological factors themselves. What's important to point out is the factors involving chronic pain development can be there from before birth. I'll expand a little bit more on this, but I hope it's clear from this graph and what I've talked about previously and what I'll share going forward, that the earlier that we can start mitigating those risk factors for chronic pain, the better the outcomes can be. So why am I angry? Because historically and to the present day, chronic pain has been pretty badly understood and treated. I put the word chronic in brackets because it's not even that chronic pain is not taught to healthcare professionals. Even acute pain education is pretty scarce. I asked one of our pain consultants the other day, how much pain education he had received as an undergrad medical student, and he said zero, literally 0 hours. A recent-ish review done in 2018 of 383 medical schools across the West and Oceania found that 96% of medical schools in the UK and the USA had no compulsory dedicated teaching in pain medicine. And the median number of hours of pain content in the entire curriculum in the UK was a measly 13 hours. And this mostly tends to be around anesthesiology or pharmacology, which is not always relevant for chronic pain. Um, with current physio training in the UK, the last physio I asked said that they get like one lecture maybe, and it's kind of around healing. So not much around chronic pain and the actual management of chronic pain that could be there for a long time, if not an entire life. Another fun fact is that people believed that babies didn't really feel pain at all until the 1990s. And there's a lot of research showing that actually early procedural pain responses, uh, early procedural pain. So, for example, if a child is in the NICU and they're getting some heel lances or kind of blood tests, doing that without any analgesia actually increases their pain responses to any procedures or pain later on. Um, I went to the International Association for the Study of Pain, their big conference recently, and one of the researchers was talking about how her daughter needed open heart surgery when she was a baby, and they did it without any analgesia at all, just completely nothing, just kind of raw dogging this open heart surgery, which is sounds so crazy to us now, but until very recently, that was just the case. Um, Another thing that gets people kind of sad is that a lot of young people have been told some pretty unhelpful things by adults around them, other healthcare professionals, teachers, friends, parents. Things like you're too pretty to have pain, or you don't suit a walking stick, you're too young to have pain. And we had to have a meeting recently with one of our young people's schools because the teachers filmed her getting out of a wheelchair and said that she was faking her pain. It's like, you really don't understand how chronic pain works, and that's a problem. So, expanding on that last point, here are some real things that our young people have been told by their healthcare professionals, teachers, or other adults around them. The drawing on the left was actually done last week by one of our young people who spent a long time being told that the pain is all in her head. And in some ways, it's true. Pain is all in your head. It's processed by your brain, and that's where the subjective experience is experienced, is where it's generated. But we know there's so much more to it than that. And quite often, when people say it's all in your head, what they mean is it's not real. And one of the main things that we tell our young people when they first come to us is that we believe you, your pain is real, and let's try and do something about it. That middle one is an interesting one. The green. Have you tried eating breakfast? So one of our young people kind of offered that when I asked what are the some of the interesting things you've been told about your chronic pain that have been really unhelpful. But actually, someone else had been in the room with the young person at the time, and actually, it turned out that the context was that this was a conversation with a chronic pain specialist about ways to improve general well-being rather than health. So, trying to eat more regularly and just all sorts of things you can do to help build routine and structure as a basis for improving pain management. But what they heard, what the young person heard was, "Have you tried eating breakfast?" So there's a lot of stuff around what people are told and what they hear, especially when they're in a stressful place. And if they haven't been taken seriously before, then there's often a level of distrust going into the conversation, even when they finally get to a chronic pain specialist. And that can color the perception of what's being said. And these are all parts of the same idea, but I think it's important to explain them all. So, one of the reasons people can get stuck in a pain cycle is because of this idea that when something hurts, that means that damage is happening in the body. This is quite often not true in chronic pain. But people will stop moving because they think that they're hurting and they don't want to cause any further damage, but that actually can make things worse. And this links into the misconception that chronic pain is always due to a physical issue. For example, an injury that still hurts after healing, or if they've had cancer. This certainly is the case for a lot of people, but unfortunately, pain can just happen. And quite a few of the young people that we see in our chronic pain clinic, they just woke up one day hurting. The other difficult idea to tackle is that chronic pain can always be fixed. So, for some people, yes, it can go away, and that's great. But for many others, the treatment aim is not to get rid of the pain, but it's to help them manage it effectively in a way that lets them get on with living. And we often use the term taking pain out of the driver's seat as a way to explain this. So, putting the young person in charge of their own life and making the pain kind of take a back seat so that they can live the way that they want to live and achieve the the goals and the values that they want to achieve. But it can be quite a big kind of mental hurdle for young people and families to get through, to accept that pain might be with them for quite a long time. There is a bit of contention about how mood and pain are linked. And most people understand and accept that an increase in pain can cause a decrease in mood, but not the other way around. But there is a lot of research on this, including a cool review by Sheng et al. In 2017 on depression and chronic pain, indicating that decreased mood can increase pain levels or pain perception. Similarly, beliefs and perception can influence pain as well. So there is a fairly well-known case in the pain world about, I think there was a BBC article about it, and there are scans online and everything. If people want to look it up afterwards, I can send some links. But basically, there was a guy working on a construction site, I think, using some kind of drill. A massive nail went through his boot, and he just started screaming in pain, as you would if a nail had gone straight through your foot. Um, so, in severe amounts of pain, was rushed to the hospital. And eventually, when they got the boot off and took the nail out, it turned out that the nail had gone like between his toes and hadn't touched his foot at all. And then, as soon as they saw that the nail hadn't damaged his foot at all, the pain just completely went away. So that often gets used as a kind of example of how, you know, how our perceptions can influence how much pain we are physically experiencing. So many things can turn our pain volume up or down, and mood is one of them. One kind of difficult thing is also pinning pain on one diagnosis. For example, something like a diagnosis of hypermobility. But chronic pain is really complex, and the diagnostic labels can be quite simplistic and sometimes unhelpful because the treatment can be directed in one way, and that broad sense of complexity isn't maintained. But we don't want people to lose hope. One kind of positive side of the fact that it is so multifactorial and broad and complex is that, yeah, it's rarely one thing that's causing the chronic pain. But in some ways, that's a really good thing because there's lots of different things that you can start to address in order to start helping to manage that pain. So, to expand on that, one way that we can be really helpful to understand chronic pain, and maybe the most important takeaway message of this talk, if you remember anything, this biopsychosocial model of pain is a really important one in the chronic pain field. So we have biological factors such as age, genetics, and muscle function. These interact with psychological factors such as mood and approach to coping with pain, which are also influenced and can influence the social context. For example, gender, where you work, where you live, how much social support you have. So these factors all interact with each other to increase or decrease pain. So one example of how these factors can increase pain is, getting stuck in that pain cycle where you're really tired, so your pain is worse, so you sleep badly, and your muscles weaken, so the next day you can't do it as much and it hurts more. But these are also all potential treatment targets to decrease chronic pain. So I really want to highlight that it's the crossover that's really important here. Chronic pain isn't just ever one thing; it's always all of them. It's really difficult to tease them apart. Everything is linked. Another one from Caitlin Berner, but this one has a little more detail about how the timing of these biopsychosocial factors can influence the pain experience over time. And just a reminder that any of these factors can be positive or negative. And this also kind of shows, throughout the life experience, the kind of the level of influence that these different factors can have as time goes on. To go into a bit more detail about the different aspects of the pain experience, I nicked this diagram from my PI, so it's really useful. It shows the interacting factors of chronic pain and how physical or biological factors such as altered pain processing and physical deconditioning can reciprocally affect psychosocial factors such as hypervigilance or mood. And so the physical changes in the body and the way that pain is processed can affect and are affected by cognitive factors like sleep and emotion. So these all contribute to the picture of chronic pain at any one time. And this individual model also sits within and reciprocally affects the wider context. So, for example, the social context, like parental protective responses. So, like letting your child stay at home from school, or peer relationships. So, if the child is getting bullied at school, healthcare factors like repeated treatment failures, healthcare professionals not believing them about their pain, or getting really conflicting messages about their diagnosis or what their pain means. And also the cultural context that all sits within. So, how much value is placed on athletic ability, for example, or stereotypes about illness and seeking help for pain. So, what are we going to do about it? How do we start solving the problem of pain? As I mentioned before, we have a chronic pain clinic at GOSH where children with all sorts of chronic pain can be referred for treatment. And this is just to give an idea of the types of chronic pain that we see at GOSH over time. It's pretty varied, and the presentations change over time as the years go on. But a really common one is, for example, widespread musculoskeletal pain, which indicates chronic pain being felt over a large part of the body. That's quite a common one. To give an example, this is a really typical example presentation that we can see each week at the clinic. And actually, I saw this exact presentation just a few days ago, like after I made this slide. So someone is not only experiencing debilitating pain, but also severely impacted function, like sleep loss, not being able to get to school, high levels of anxiety. Many of the teenagers that we see have either been diagnosed with or are awaiting a diagnosis for autism or ADHD as well. So there's a lot of neurodiversity going on within this cohort as well. And the physical function is often a lot lower than you might expect, even if there has been a precipitating injury or disease. The pain can sometimes be a lot worse than, for example, the inflammation that they might have would suggest. So we're starting to see a picture here that pain isn't just about physical pain; it's also everything else around it. Moreover, these young people have often had quite an arduous journey to get to their chronic pain clinic referral. They've often been seen by multiple different departments who shrug their shoulders and pass them on to someone else. And they've often tried a variety of treatments without any meaningful success. And this is an overview of the large sample of the young people with neuropathic and musculoskeletal pain that come through the chronic pain clinic. Just to show that nearly 90% of these kids are scoring a low quality of life, which is under the ideal amount of 70 or above. This graph talks about pain catastrophizing, which doesn't necessarily speak for itself. So I'm going to explain that measure a bit. So this is a really commonly measured factor in chronic pain research, and it consistently shows itself as a mediator and predictor of long-term pain. It's split into three domains. So rumination or worry. So, for example, thinking constantly about your pain, not being able to turn those thoughts off. Magnification, or the idea that the pain is a disaster that will never go away. And helplessness, or the idea that the pain is totally out of control and you can't do anything to manage it. The fear avoidance model on the bottom is quite helpful in explaining how catastrophizing can be a maintaining factor in the pain. So, essentially, the idea is that having a pain experience and also being fearful and ruminating a lot about the pain tends to cause an avoidance of any further activity that might result in having another pain experience, which can feed into that cycle of losing energy and ability to do activities of daily living. And then when you do them, there's more pain because you've lost some energy or lost some muscle mass. And the cycle just keeps going around. So, if you can break that cycle of fear and avoidance and pain, recovery can start to happen. And people more prone to catastrophizing are more at risk of getting stuck in that pain cycle. So, it's a really important measure to look at and to target when we're looking at trying to help people manage their chronic pain better. So that graph on the right is showing that for pain catastrophizing for our chronic pain kids at GOSH, about three-quarters of the young people that we see are scoring in that moderate to severe range of pain catastrophizing. Many of the young people are also scoring quite highly in terms of emotional distress. So, ideally, with chronic pain treatment, we want to see an improvement in all of these numbers, like quality of life, pain catastrophizing, and emotional distress, to name a few important ones. So, most chronic pain clinics and research centers work within the biopsychosocial model of pain. And this is approached with what we call the multidisciplinary care. So, where multiple healthcare professionals work together to provide well rounded treatment that considers all of these biopsychosocial factors. So, for example, pain education, pharmacological treatment if it's needed, psychological treatment, and physio treatment. So, the usual multidisciplinary chronic pain treatment model in place at GOSH, new patients are seen not only by a pain consultant, but also in the room or in the appointment are a physiotherapist, a nurse, and a psychologist who all work together to discuss the best way forward for each particular patient that they see. This may include a change in medication, but also a lot of psychology support, physiotherapy sessions, and or social care support. Usually these are delivered at separate outpatient appointments going forward. So far this has been pretty effective, but there are some limitations. So, for example, it can be quite hard to maintain the efficacy of handover between different disciplines, even within, one hospital. So, talking between different hospital departments. And while there are improvements in quality of life, many young people's quality of life still remains below that target 70% that we want to see. This approach can often rely on local services like referring people to CAMS for psychology support if there are no appointments available at GOSH or if we think that they're more suitable for local services. Um, we don't really know how long the positive effects endure after they're discharged, usually at about 2 years. And as I said, whenever a sample was assessed for quality of life scores, over half of them still scored under that ideal level of quality of life when they were discharged. So we are seeing increasingly complex cases at places like GOSH where young people are still struggling despite multidisciplinary care. So what we want to know is how can we improve on the multidisciplinary model? One approach is by making it interdisciplinary and intensive. So IDT stands for interdisciplinary treatment rather than multidisciplinary treatment. So this interdisciplinary approach promotes a closer enmeshment of multidisciplinary services, where professionals are working really closely together to provide comprehensive care in one setting, often delivered through a program over a number of weeks where the patient receives intervention every single day. Some centers have been trialing this intensive program approach, and they've had some good results with reduced disability and improved quality of life following discharge compared to usual outpatient care. And that has shown to be sustained after 5 years. So just a graphical representation of that last slide. So this is some data from a pain management program in Boston, which uses that intensive interdisciplinary approach. And they see reduced disability and increased quality of life at discharge from the program and then a 5-year follow-up. And then on the graph on the right, we can see that there have been decreases in pain intensity, pain-related disability, and also an improvement in pain-related school or work absence, and that is usually mostly maintained at the 5-year follow-up, which is pretty promising. An expansion on the data from Boston shows overall reductions in actual pain levels, as well as those quality of life and ability improvements. Interestingly, they saw some grouping of the data going on where young people tended to respond either quite early on and show large improvements by discharge, so the end of the program. And then they have a group that they call late responders who don't tend to show those improvements until the 1 month follow up. And then there's about a third of them who don't really respond at all. There's still a bit of a reduction in pain going on there, but they're referred to as non-responders. And interestingly, they found that there are certain variables that predicted the odds ratio of being in the non-responder versus early responder group, including age. So if you're older, you're more at risk of being a non-responder. Your level of pain at admission, so the higher your pain is at the beginning of the program, the more likely it is that you might not respond as well. Social functioning. So interestingly, in this study, better social functioning meant more risk of being a non-responder. And also, as you might expect, higher anxiety predicted more chance of not responding. And those who were in a lower state of being ready for change were also more likely to be in the non responder group in terms of pain reduction. So, Bath here in the UK, they also run an interdisciplinary intensive pain program for young people, which is based on acceptance commitment therapy. So, young people stay for between 1 and 3 weeks. They receive physical conditioning, activity management, and psychological intervention. But the ACT ACT framework is consistently applied throughout all of the sessions, with an emphasis on how behaviors serve short and long term outcomes, focusing on acceptance, mindfulness, and valued living. So, increased function is the primary target. And since pain can't necessarily be taken away completely, and they're working towards managing pain and the related thoughts and emotions through acceptance therapy and focusing on the present moment. They are assessed, these young people are assessed on a bunch of measures and then followed up at 3 months. So far, their program has found to improve all aspects of function in young people, which is really cool. Also, reduce depression and increased psychological flexibility in parents, which correlates with improved child pain acceptance. So, the intensive interdisciplinary approach looks really promising. And we have an idea of which factors to target and measure, but we do need more stringent evidence in the field, with ideally longer term follow ups so that we can assess what happens later down the line as people grow and develop into new stages of their lives. So, what does an intensive interdisciplinary approach look like at Gush? So, what happens now? We've developed this intensive interdisciplinary program. So, when a child is now referred to the chronic pain clinic, they have the option of usual outpatient clinical care. So, psychology, so separate psychology appointments or physio, rehab, or anything else that they might need delivered separately. Or if we think that they might greatly benefit from an intensive pain management program, they're referred to us, to the Hummingbird program. It's called Hummingbird because all wards or units at Gosh have an animal name, and we're right up on the seventh floor. So they went with Hummingbird. Personally, I would have preferred something really badass like Harpy Eagle, but Hummingbird does mean that we get some really cute colors on all the walls everywhere. So that's quite nice. Patients come for 3 weeks with a parent or carer, and they attend every single day. They either stay at a hotel nearby that is funded, or they commute in every day if they're close enough. We assess them at the beginning and at the end of the program, which I'll discuss later on. And we also assess them at 1 month, 3 months, 6 months, and a year. And going forward, we're hoping to follow them up for longer periods for up to 5 years. So we start with getting the groups to know us and know each other. Each of the 3 weeks has a theme that encourages the young person and family toward ultimately being able to self manage their pain. So, week 1 is about onboarding. Week 2 is all about consolidating those ideas that they've learned. And then week 3 is really moving towards that self management. Um, each week also includes all of the following sessions. So each day includes these 5 sub themes that aim to encompass the interdisciplinary aspects of chronic pain treatment. So we have move sessions, so engaging in meaningful physical movement, pain management skills practice, reducing the fear of movement. And we have discover sessions, so providing credibility for action, introducing new content and pain management strategies with rationale. So, like making change in your life, talking about sleep routines. Do sessions, so putting that learning into practice through opportunity enrichment and everyday activity, using problem solving and planning. So, that might involve just going out for coffee. So, a lot of young people with chronic pain um, quite often don't go out anymore, or they're not socializing with their friends very much. And even just going out for coffee and having, getting that confidence to go up to the barista and order what they want can be a really huge thing for them. Or spending more time outside and being physically active can be really, really impactful. And then explore unwind sessions. So that's more about interoceptive awareness, relaxation, mindfulness based practices, and self regulation. That last section, explore and wind, has been quite interesting. So things like yoga work really well in young children and in adults, but in teens, it maybe seems to be a bit trickier. And this is why we think that teenagers are a really great area for research, because they're sort of in a gap in a way. And there's so much going on in terms of like identity development, social development. They're in that transition between childhood and adulthood. So mindfulness and things like yoga do work for many people, but we don't maybe know how well it works in teenagers and how we can adapt it to work better for this age group. So then they're at an age where they can learn a lot and they can understand a lot, and we can speak to them like adults, but there's also a lot of context surrounding that. Um, it's also important to point out that we also have parent sessions specifically for parents as well. So parents do a lot of the sessions themselves every day, and group work, as well as joining in a lot of the kids' sessions as well. So the actual physical space is called the Maria Fata Centre, after the family who donated the funds for the program and the research. This is the team. So we can really see the interdisciplinary approach here. So each session involves multiple team members. So for example, the physio-focused move session will not only involve a physiotherapist, but for example, also a clinical psychologist might be in the room as well, engaging in that session, and they work together to deliver the session in a really interdisciplinary manner. I think we have one of our physios, Harriet Yale, in the corner there. I think she's also in this talk. And if anyone has any physio related questions, or any more kind of clinical questions, then please do write them in the chat, because hopefully Harriet can help answer those as well. This is just a few photos of the space that we have. We've got a really big activity room, and we've also got a bunch of smaller areas and a lot of cool artwork. And that picture in the bottom corner of the tree with all the hands on. So that's now a lot more, there's a lot more added to that now as we've had more groups come through. So the young people can leave messages for each other and for the future groups going through. Um, all families receive a workbook, one for young people and also one for the parents, which covers a lot of the themes that are shown here. We can see that there's a lot of focus on change. So changing the way that life is lived, changing the way that pain is dealt with. A really important aspect is that it's not necessarily about taking the pain away for these young people. Sometimes pain does resolve completely, but unfortunately, quite often that's just not possible. But what is possible is helping the young people better manage the pain. So, as I mentioned before, kind of helping them put pain in the back seat rather than letting it drive their life. So, ultimately, leading to improved quality of life and function, as we saw in the results from other centres that I showed a few slides before. We're hoping that we're going to see some similar results here, and that these will be sustained into the long term follow up. So this is where I come in as the researcher. So this program, this Hummingbird program, is set into a research context. So we have something called the Piccolo study, pediatric chronic pain clinic longitudinal cohort. So this is where we're collecting some basic outcomes from all families that come through the chronic pain clinic. So not the program, but just the chronic pain clinic, where they're receiving regular outpatient appointments. And they receive usual clinical care. And this serves as a comparison group to all the young people that come into the program. And the research on the program itself is called PIPER, so Pediatric Intensive Interdisciplinary Pain Rehabilitation. So we're currently running a bunch of soft launch programs while we've been waiting for the research contract to be finalized. But it's been a really useful time to refine the intervention kind of on the clinical side of things. And we've developed the program from scratch. So the last year has been a really interesting process of seeing what works in the program and what doesn't, in terms of things like timetabling and fitting all the sessions in a way that's most feasible and most clinically helpful for the families that we've seen. So we've had 9 programs in the soft launch so far. That's about 30. Yeah, we've had 36 young people through in groups of between 2 and 6. But now all the research preparation is finalized and we're ready to start the actual research study itself, which is really exciting. So what are our specific aims with the research? The main aim is to establish and deliver a pediatric pain rehabilitation or management program at GOSH. A primary research question for this research that we're doing in general is, for adolescents with chronic pain and pain-related disability, does an intensive interdisciplinary pain rehabilitation or management program, compared to usual care, improve functional and psychosocial function with sustained benefit throughout our long-term follow-up. We also want to know, is an intensive pain management program cost effective? Can we predict which patients or young people are most likely to benefit from a program like this? And generally, what is the burden of chronic pain in children, especially in the UK? We do have some inclusion and exclusion criteria for the research into the program. I won't go into all of them, but there are some immediately obvious limitations that you might pick out. Um, so things like the parent or carer being unable to attend. So it's a really big ask for a parent to take 3 weeks off work. We do provide accommodation if needed, and we do allow free time every single day for the parent to take a few hours off to, do online meetings or whatever. But they do need to be in the center with their young person. And also, if they're staying in central London or commuting in central London every day, having to buy food and things like that in a central London area can put a really large financial burden on families. And one really important part of the observational research, so the kids that are just coming through the usual care chronic pain clinic, um, it'll be interesting to assess which of those families declined the program due to those prohibitive issues. And that will give us a really important amount of data on where those inequalities lie and how we can move forward in addressing these. This is our research process. So we run a 3-week intensive program. Both the young person and their parent or carer attend every single day except for weekends, although the weekends are incorporated into the kind of the session planning. They're followed up for at least 1 year, and families can eventually opt into being followed up for up to 5 years to assess their long-term trajectories. So, a recent Delphi paper described which outcomes are most important for pediatric pain research. So, we have mandatory domains, we have important but optional domains, and we have useful research agenda outcomes. And in our research, we are trying to follow those as best we can. So, in terms of mandatory domains, we are measuring pain severity and pain interference, overall well-being using the pediatric quality of life questionnaire, and we are measuring any adverse events that come up as a result of the intervention. In terms of the important domains that were mentioned in the Delphi paper, so we are measuring emotional function, other psychological factors such as pain catastrophizing, which I mentioned before as being really important, and fear of pain as well, amongst some others. And we're also measuring a bunch of physical function variables too, and things like sleep disturbance as well. And then, in order to assess the broader research themes, we're also looking at service use. So, how much healthcare the family is needing to access over time and the economic cost of this, as well as working out how much it might cost. So, the cost to the families and then the cost to society as well, or the NHS. And then we also measure how well the program is delivered and attended. We call that treatment fidelity. And we're also hoping to eventually include some potential biomarkers in the future. So we might look at fMRI, using fMRI to look at any neurological changes we might see during the program, and things like quantitative sensory testing as well. This is the research or program timeline for the feasibility study. So when I refer to randomization in this slide, so we are doing a feasibility study first for a year, where we randomize people into joining either the program as soon as they get referred to the chronic pain clinic, or they're randomized to the delayed group where they receive 6 to 9 months of usual multidisciplinary care through the chronic pain clinic before they come to the program. So this will give us an opportunity to examine whether it's better to jump straight into the intensive interdisciplinary treatment, or whether it actually is better to receive some usual care first and get used to the idea of chronic pain and how it works before then attending an intensive program like this. And it also gives us lets us assess some program versus non-program measures without that ethical dilemma of refusing treatment for some people and not others. So unfortunately, I can't present our preliminary data today, but I think I can say that it is looking pretty positive so far. And we are aiming to publish methods and early data paper sometime in the near future. So if anyone is interested in following up, please do get in touch. And yeah, we can keep in touch about that. And finally, I'd like to share some feedback from the families that we have had through so far. I've removed all of the gender and age identifications, but otherwise everything is verbatim. And one I want to point out is the one in teal on the right, middle right. So my pain has lessened and improved a very noticeable amount since the program. It's not gone, but I obviously didn't expect it to be. I feel as though it's played a significant role in improving how I deal with pain. So I think that one showed just so much insight about the realities of pain management. And we can't wave a magic wand and take the pain away, but we can provide lifelong skills to help people achieve their goals despite living with chronic pain. And the earlier we can help them do that, the better the outcomes will be. So thank you so much for listening, and I look forward to hearing all your questions.
Brilliant. Thank you so much for that talk, Anna. That was really great. We're now going to take a 15-minute break. And folks, in the break, please remember to submit your questions or read through the ones that have already been submitted and upvote the ones that you really want to see answered. So as I said, we'll take a 15-minute break. So we'll be back at 8 p.m. British summertime. See you in a bit. Okay, welcome back. I hope you enjoyed the break. We are now ready to go into the Q&A with our guest, Dr. Anna Fieldwalker. So our first question for you is, do you have any pets? And if you do, show us them.
I cannot show you because I do not have one because I live in rented accommodation. But there actually is a very cute black and white, very young cat that started creeping into our garden. And I'm in two minds about it because it's a very cute cat and I wanted to pet it, but also it's scaring away the really nice birds that we get in our garden. So if anyone has any suggestions on how to make cat friends but also keep the birds happy, pop those in the chat as well. But yeah, no pets I can show you. I'm sorry.
Okay, well, we'll forgive you. So our first proper question comes from Andrew, and they ask, is there not much medical teaching on pain because it's seen as a symptom of other illnesses rather than an issue in itself?
Yeah, that's possible. So I will mention right now that my our amazing colleague Harriet, the physio, is on chat with me at the moment, and she's also typing some stuff in to help answer these questions. So thank you and shout out to her as well. Yeah, that could definitely be the case. I mean, as Harriet is saying, the goal of healthcare is to fix, not to manage. So there's a bit more focus on acute versus chronic conditions, and that's kind of maybe why the little pain education that there is in medical training is kind of focused on things like pharmacology or anesthesiology because it's all about those acute acute conditions. Whereas chronic conditions are just, there's more complexity going on. It's more difficult to treat, I suppose, and it's not really about curing something. It's about managing, like what could potentially be a lifelong thing. There are limited medical treatment options in terms of things like pharmacology. So actually, like pharmacological analgesia, so pain medication, doesn't actually work that well for chronic pain. It's more kind of therapeutic options that are the kind of focus of things. But it also doesn't really, chronic pain doesn't feature that strongly in therapy degrees, at least, 10 years ago. I'm not so sure what it's like right now. And yeah, chronic pain doesn't really fit into one silo as well. So it is quite difficult for any one profession to spend a lot of time talking about it. But I still think it's really important. And I still think they really should, especially medical degrees, because they're seeing people with pain all the time. And yeah, there just needs to be a bit more education about how to deal with it and how to talk to the people that are in pain as well. Yeah, sorry, that's not a definite answer, but I mean, a lot of my answers are going to be sorry, that's not a definite answer, but yeah,
We like those. Like, a lot of stuff
best.
doesn't have like easy, definite answers, which
Yeah.
is why we don't have them yet.
I don't flipping know.
Yeah. So you mentioned that just then the chronic pain tends not to respond as well to analgesics. Do you have a sense of why that is?
Um, I think mostly because all of those factors that go into chronic pain, that the psychological and the social aspects, your social situation. I mean, there's not really a painkiller you can take to fix social situation. Although interestingly, there was a really, really interesting study that I remember hearing about in my undergrad pain psychology class that was like they did a study using painkillers to treat heartbreak and seeing if that was more effective than not. So I think they got like a bunch of people that had just gone through a breakup or something, like really problematic study and not well controlled at all, probably. But they found that people that took the painkillers were feeling less emotional pain afterwards. So there is. I don't know, that's just interesting. But yeah, the fact that the whole like biopsychosocial model of chronic pain means that yeah, moving forward with it, it's all those other factors of your life that need to be addressed and treated, not just what signals your spinal cord is sending. Certain medications can be more or less helpful for certain types of chronic pain, and we do use pharmacological analgesia for chronic pain patients, but in the long run, it's not always super helpful. And a lot of our young people say, I've tried ibuprofen, I've tried paracetamol, or I've tried codeine, and it's just not really helping. It's not doing much.
Okay. Something that occurred to me sort of during the talk was, I guess it must be like, do you know how to strike the balance between talking about therapies and the ways that people's lifestyles can be changed in a way that's kind of empowering without sort of slipping into like potential victim blaming of like, of course you've got chronic pain, you have like terrible like sleep habits. Like how
Yeah.
do you walk that line?
Yeah, oh, that's really funny you mentioned that one actually, because yeah, Harriet and I were just talking today about how in the session about sleep habits and how do you make your sleep better. It's a lot of like parents looking at their kids, saying like, "See, I told you," or like the teens looking at their parents, being like, "See, I need more sleep." Um, so even within families, there can be you've got to create a space for letting people talk openly um, about the issues that they're dealing with, but also kind of like how you can improve those things. I guess it's like any kind of treatment or therapy that you get. It's like, okay, you're dealing with this problem and your problem is real and it's really difficult and it must be really hard for you. And it's no wonder that you're struggling because you're dealing with a really difficult thing that a lot of people don't ever have to think about dealing with. Um, but here are some things, and here's what the research says could be really helpful for you. How about you give it a go? And it's not about lecturing people or saying you have to do X, Y, and Z, otherwise nothing is going to help. It's more about kind of giving people lots of different options and saying, not everything is going to work for you, but try these different things, and you can take what you find most useful to you and kind of put it in your toolbox, is what we call it, to move forward. I hope that's an answer that helps.
So, leading on from that, a question that's been submitted by Gail is specifically: is cognitive behavioral therapy useful? Like,
Yes, it is. Yeah, absolutely. So the program is actually based on a mixture of cognitive behavioral therapy and the acceptance commitment therapy model. But it's also interdisciplinary, so it has more than just the psychological interventions. It's got kind of the other kind of physio and a bit of medical management and occupational therapy as well. So yes, definitely CBT and ACT are really helpful, but it's kind of set within that wider context of the biopsychosocial interdisciplinary model. But yes, short answer, yes, it is.
great, great. Our next question comes from Eagle, and they ask: is there a fundamental physiological difference between chronic pain and regular pain?
um, Possibly. I mean, there is the kind of idea of central sensitization going on with chronic pain. So there is a lot of research going on about central sensitization at the moment. You may have heard that term. There's a lot of debate in the chronic pain research world about what central sensitization actually means and what you can define as central sensitization. And that is often kind of used as an example as a physiological difference that happens with chronic pain, where you get basically your body becomes more sensitized to, for example, incoming, like touch, for example. But fundamentally, there's a lot of similarities in terms of how the pain is processed in the brain. With which really Harry it sounds with the neuromatrix model. So lots of different factors like are discussed in the biopsychosocial model that go into the pain experience. But central sensitization is kind of a main difference that you can look into. The idea that nerves that fire together, wire together, or that well-trodden path in your brain. So the more pain that you're experiencing as time moves forward, you get that kind of sensitization going on in your body or in your nerves. So that is one particular difference. But there's still a lot of, it's not always a clear-cut difference going on.
Yeah. I think there's something else that occurred to me during your talk and through one of your answers, was I started to wonder about, does it make sense to talk about pain as one singular phenomenon rather than or because obviously there are different types of pain. Like, would it make more sense to break it down into different types of pain, or like, does it not make a difference and pain is pain?
Yeah, well, good question. I don't really know. I think it depends on. I mean, at the moment, we're kind of, as I alluded to earlier, that kind of difficulty you get with trying to pin something on one diagnosis can provide some kind of like ease of understanding what you're going through, but then it could also provide a kind of introduce problems where you're not kind of thinking broadly enough. You can kind of There's the idea of symptoms of distress as well that can be lumped in with pain. Um, yeah, it's yeah. I think in some ways it's really helpful to think of pain as one thing, but just to be aware and to have that understanding and that education around that biopsychosocial model and how there's so many different factors. Like pain is also distress, or social difficulties, or and it kind of leaches out into things like neurodiversity. Um, yeah, it's big, it's broad, it's complex.
Yeah, yeah. So we have another ego question, and they ask, how good is our understanding of the pain phenomenon actually? And then ask, do we know everything there is to know about it? I feel like I can answer the second half of that question as no.
No, I mean that's why we're doing more research,
Yeah.
and why we need more research, because I mean we're learning more and more as time goes on, about both the kind of physiological aspects of how pain is processed and how our bodies are able to deal with pain and different types of pain, um, and also the kind of more general, what's best for different types of chronic pain. But yeah, there's so much more that we need to know. Like that's kind of why we're doing our study is how can we predict which people will respond the best to things like pain management programs. Yeah, there's so many different influencing factors. We're always kind of uncovering more and more things that can be useful or can have influence. There's social, cultural, spiritual factors that can go into it, and it depends on your different, what your context is, where you are in the space that you're in. We're still learning a lot about how those things interact, even within like different healthcare settings can be so different. So no, we don't know everything, and that's why we need more pain researchers. So please come and join the world of pain.
That sounds so sinister, but also very
Mwahaha.
inviting. um, so our next question is submitted by Anonymous, and they ask, is there a different is there a difference in in the way chronic pain management is approached in like chronic headache versus other physical chronic pains?
Um, is there a sorry, could you repeat that question again?
Is there a difference in pain management approach for chronic headaches versus other chronic? They've phrased it physical pain, but I'm guessing
Um,
I suppose that like I I imagine like limb based pain rather than headache.
yeah. There shouldn't really be a difference. I mean, if it's all chronic pain, right? But quite often they are differently differently managed. So, I mean, I'm referring to from my friend Harriet here. Apparently, headaches are currently quite medically managed compared to other types of chronic pain. But based on the research, it should actually be the same. All pain can be managed in the same way, and all strategies could be helpful for any person experiencing chronic pain, no matter where it is. We do have some chronic headache young people with chronic headaches who will be coming into our program or have been part of our program. So we are starting to, at least in Gosh, we're starting to come together with that and realizing, or talking to each other and realizing that we need to, yeah, communicate more between departments and try and figure out how best to treat the issue. But yeah, there is a bit of a difference, but shouldn't necessarily be a difference.
And following on from that, another question from Igor: what is a migraine?
What is a migraine? Indeed, that is that's a big question. Um, as far as I know, we don't really know. um, there is a really great migraine team at Gosh who did come and speak to us recently. As I said, we're thinking about merging our resources more. But as far as I understand it, we don't really understand that well um, how migraines work. There's a lot of uncertain pathophysiology going on there. There could be, unknown influences. I think there are some kind of uncertain, but could be hormonal influences going on as well. It changes, I think, as time goes on. Um, in terms of who's more at risk of having migraines changes across the lifespan. So there are some, obviously, maybe some developmental things going on. But yeah, migraines are really difficult to understand and to manage as well, I think. But yeah, it's just a kind of another kind of yeah, type of chronic pain that um, we want to start helping to treat with chronic pain. Intensive interdisciplinary management should be helpful for it. Yeah.
It's really interesting that you said that headaches, and so I'd assume that'd include like migraines and similar, tend to be treated more medically. Um, I suppose that got me wondering, like, are there types of pain or areas of pain presentation where patients find that they get taken more seriously, or doctors are more willing to investigate and try and find an appropriate medication versus others?
Mm. Um, yeah, I don't know. Is the answer to that one. I think it really depends on how much education like any one healthcare professional has. Um, it depends on because there are some chronic pains where there are there can be effective treatments for a pain in that area. And in that case, um, it might be more well known and they might be able to receive kind of quicker help for that particular type of pain. Um, but yeah, I think it does depend on who you end up being seen by. So, for example, Harriet's just popped in my chat. Nerve blocks are used in migraine, for example. So that is kind of like can be a quick fix option. Doesn't always work for everyone. So I think there was a young person we had recently. with kind of head pain, and they tried nerve blocks and it didn't work at all, which can be really crushing
Mhm.
as well for a young person if you get told like, oh, here we have this thing it's commonly used, let's do it, and then it doesn't work, and that's like, oh, that's so gutting. um yeah, chronic pain, it's so multifactorial that it's difficult to try any one thing, and that's why one thing quite often won't work. It's that idea of trying to address all those biopsychosocial factors in someone's life. So kind of treating yourself as like a whole human can be really, really helpful. And quite often people only address the biological side.
Mhm.
um, Whereas if you start thinking about yourself as a person and your experiences and the situation, the context that you're in, um, you hopefully start to see some much more impactful changes.
Our next question comes from Lady on the Farm. And they ask, how do we get doctors to treat or even investigate chronic pain concerns rather than dismissing a patient as having just anxiety?
Um, yeah, that's hard. That happens a lot, and we hear that from our young people a lot. Is I think that's kind of the part of where the "it's all in your head" message comes from. I think when people say like, of course, anxiety can affect chronic pain, and it can make chronic pain worse, or chronic pain can make anxiety worse as well. But that's not the whole picture. Again, you've got to have that biological, psychological, and social um, you know, factors being addressed together. Um, Thinking about communicating with doctors, it's really tricky. Um, Understanding pain yourself in order to advocate, for what you need, perhaps like try and understand what your triggers are, to be able to kind of communicate those and you build a better understanding with your healthcare professional about what's going on for you. Often acute pains are kind of limited to ruling out serious pathology. And once that's done, seeking therapeutic support from a chronic pain physio or a psychologist could be really helpful. So, seeking out the people that will probably have a better understanding of what chronic pain means, and for you specifically as a person and your context. But yeah, it's really hard, and a lot of the time you do have to advocate for yourself really hard and loudly in order to be heard and treated. And it can be a really long journey, and often has been a really long journey for a lot of the people that we see, unfortunately.
Do you find, especially sort of on that point of um, communicating and advocating for yourself, is that an area that where you especially see difficulties with neurodivergent patients?
Oh
Because
yeah.
often, obviously, neurodivergent patients don't express their pain in the way that is like expected by clinicians. Is that something you're
Yeah.
saying?
Yeah, it can be. Yeah, again, I would recommend reading Caitlin Borona's work. She's been doing a lot of really cool stuff into neurodiversity and chronic pain. And there's a couple of other really cool researchers. I'm terrible with names, so they all slip down my head, but there's a bunch of them, and I can find them and send them to you to send to people as well, who are doing some really, really great research on autism and chronic pain, and how that affects the kind of communication between healthcare professionals as well. Um, Definitely take someone with, if you're a neurodiverse person who may struggle with communication, take someone with you to help advocate for you at any appointments that you have, for sure. And try and um, yeah, understanding your pain and understanding the biopsychosocial social model, so that when you are in the room with a healthcare professional, you can kind of hopefully try and explain some of that stuff to them, or your advocate can help explain some of that to them as well. Um, but yeah, definitely can have an effect, and especially as neurodiversity is so common with chronic pain. Like, I would say maybe more than half of the young people we have coming through the program have been diagnosed with autism or are awaiting diagnosis. And that's kind of has become part of the development of our program, is that we've kind of realized that that's such a big thing. Harriet's just messaged me the statistic that 1 in 2 people with autism spectrum disorder have chronic pain, which is huge. So it's
Really
definitely
nice.
something we all need to be aware of as chronic pain researchers. And it has affected how we develop our pain program, because it's so common, and it feeds into a lot of how we've developed some of the sessions around communication as well. How do you communicate with someone about your pain? So for someone who isn't neurodiverse, maybe they'd find that session really kind of, why do I need to learn about how to talk about my pain to people? But actually, for at least, half of the young people we have, that's a really relevant and really, really impactful and useful sessions for them.
Yeah.
Yeah.
Our next question comes from Igor again, and he asks, is there some magical cheat code that helps convince a doctor that your pain is real and that they need to do something about it?
Yeah, again, um, no magical cheat code, unfortunately, and it depends on the doctor that you end up seeing. Yeah, again, really, um, I really encourage understanding your pain, learning about your own pain in order for you to advocate for what you need. Again, understanding what the patterns might be in your kind of chronic pain experience, what triggers you might notice. Whether I don't know, some people find that their chronic pain, they'll have a pain flare up in the summer or the winter, or when they've done a certain kind of activity, and kind of noticing all those things and building as big a picture as they can for themselves to take with them to the healthcare professional and say, um, you know, I've done a bit of research on myself and this is what I found. But yeah, it's tough, and yeah, I think it depends on someone you've got. But hopefully, as we do more pain research and we get louder about what it is and how to treat it, then that will get less and less of a problem in the medical world.
Yeah.
Fingers crossed. It's helpful not to expect the doctor to just understand, um, and work to explain what's going on for you. Um, you could even share this presentation with them if your doctor is up for spending an extra, hour and a half watching a presentation on chronic pain. But there's loads of really cool educational tools out there as well that you could bring along with you, or look at yourself, and then kind of give an overview to your doctor if they're not already educated on what chronic pain is. Yeah.
Our next question comes from Gray the Earthling, and they ask, if swearing increases your tolerance for acute pain, is there something analogous that can mitigate chronic pain? Can you just swear constantly? Doctor's orders.
I love that one, because my mum always used to tell me growing up that she's a vicar, by the way. She's a Church of England priest, and she always advocates for swearing to reduce stress. Um, um, yeah, I mean, I guess there's a lot around trying to reduce stress levels for chronic pain, and again, like during those things that kind of let your frustration out, can be helpful. Again, it's very personal to each person. Like, what relaxes you? What can you put in your toolbox that at any point when you're experiencing stress or an amount of pain, you feel your pain rising, what are the things in your personal toolbox that you can kind of latch onto? And maybe that's swearing for a bit or screaming into a pillow, um, just to try and bring that stress level down and try and calm those pain signals. Um, and yeah, for you, that might be swearing. I don't know if there's any research on swearing for mitigating chronic pain episodes, but I'd love to do research on that. Um, Maybe I wonder how far I would get with a with a research proposal, like a grant proposal for that. Um, yeah,
Yeah. Teaching
yeah,
adolescents how to swear for all their health.
yeah, yeah, yeah. Yes, I will probably get in trouble for that. Just on that last point, There's a video on YouTube called Explain Pain. It takes 5 minutes. So if that might be useful for anyone has chronic pain and wants to go to the doctor and they're not sure if their doctor will understand, that YouTube video might be super helpful. So Explain Pain, if you just Google that, that might be helpful.
Our next question comes from Andrew, and they ask, do different genders actually experience pain differently? Or is it more, for example, men need to man up while women are more likely to seek healthcare if concerned?
Yeah, it's not just that. Um, there's a lot of research that's been done now and in the last couple of years around sex and gender and chronic pain. So again, Caitlin Boner has been doing some really cool work. Ed Keogh at Bath has been doing some work recently and well, for a long time on this actually. It's not just your own gender as well. It's whoever's in the room with you. So they've done a bunch of experiments. I think Ed at Bath has been doing some cool research on when the gender of the person in the room in front of you changes how the way that you respond to, like pain stimulation or something, which is really interesting. And yeah, there are those gender-based beliefs that can influence how you experience pain. I think there is a bit around if you have kind of more traditional masculine beliefs about men need to man up, they might be less likely to seek healthcare. I think there is some of that going on. And also there's the cultural context as well. So different cultures have different opinions on how much you should seek healthcare for pain. And also it depends on age. So as you age, there's a bit of research, I think, in the Parkinson's world, where a lot of older people will report not asking for pain relief or not seeking help for pain because they're like, well, I'm old and it's just a part of aging and I shouldn't be complaining and I'm a burden, things like that. So there's all sorts of stuff. Sorry, I'm going a bit on a tangent, but yes, it's not just that. I don't think it's just about seeking healthcare. It's also about it can be about how much pain they experience as well. I mean, it's quite difficult to tease apart, what is just pain reporting and what's the difference between that and what might be physiologically going on in the body. But again, pain isn't just what signals are going up and down in your system. It's everything around that's still important. But yeah, those researchers that I've referred to before, please go read their papers. They're super interesting. Masi Moyedi as well has done some cool gender research. And also there's quite a bit more research going on now on gender diverse individuals and how their experiences change with chronic pain. So trans women will experience pain differently to cis women and to cis men as well. And there's a lot of research coming up on that that's super interesting and really, really needed right now. So yeah, go and check that out.
I guess, like, generally, it's a very difficult thing to compare people's subjective experiences. Like, how does one measure, like, the extent to which one person experiences pain compared to another? Like, if you take the sort of one of the classic experiments of, so the swearing experiment that got the Ig Nobel, it was people submerging their hands in ice cold water, and the findings were that the people that swore continuously while they had their hands in the water could keep their hand in the water longer. But two different people keeping their hands in a bucket of ice cold water, are they having the same subjective experience? Like, if one of them can hold it in longer, is it because they've got more tolerance for pain, or are they getting fewer pain signals? Like, it's such a difficult thing to tease apart.
Yeah. I mean, until we're allowed to stick recording needles into people's spinal cords to measure the responses of those like dorsal horn neurons, like we do in animals. I mean, not me personally, because I think rats are really cute, but my friends do it, and it's really cool to watch those responses happen live. But yeah, we can't really do that in humans yet. So yeah. it's difficult to say. I mean, you just need to get loads and loads of people and loads of data, right? And try and capture as many variables as you can without destroying your kind of level of effect that you're trying to find. So we have quantitative sensory testing, which is kind of like I would say maybe a halfway point between, just general reporting pain and things like that, and the kind of measuring the actual physiological responses. So quantitative sensory testing is where you measure thresholds in terms of thermal and mechanical responses. So you're measuring how quickly someone can detect when something is getting hot or cold, and then also when that experience becomes what we call nociceptive. So when you start to get that burning, tingling, or aching feeling or sharp feeling. So we're kind of differentiating between when someone is just experiencing a normal, just a temperature, and when that becomes when your nociceptors start to react. And then the same thing with mechanical thresholds as well. So you'll just kind of poke people with different weights, and then, okay, it's like, at what point does that become a sharp feeling? Which helps in a way because you're asking when it's becoming sharp, not when it's becoming painful. So you are kind of taking away a little bit of that, maybe some of that bias around what should be painful and what shouldn't. It's just like, does this feel sharp or not? And then you're getting that information about when are those pain receptors responding in your hand, for example. So that's used a lot in pain research, and that can get us some of the way in terms of trying to get a little bit more of the objective somatosensory picture. But yeah, again, it's pain, it's complex, there's so much stuff going on there. It depends who's in the room, who's doing the experiment, how you're feeling that day. All of those things influence pain. Yeah.
So we have another anonymous question, and they ask, in the aftermath of the pain management opioid crisis, especially in the USA, have there been any developments in pharmacological approaches for chronic pain? And thank you. They say thank you as well.
You're welcome. Yeah, there's a lot of talk about the opioid crisis. Yeah, especially like the last conference I went to, like so many of the North American researchers were talking about how to manage opioids in young people. I'm not really sure because I'm not a medical doctor, so I don't have any pharmacological training. So I would have to kind of point you towards, some of those papers that people have been doing, some of the research people have been doing. I think a lot of people have been trying to find alternatives, and trying to figure out other ways of dealing with chronic pain. So things like like lidocaine patches or capsaicin, or other kinds of non-steroidal anti-inflammatory drugs. But it depends what kind of pain you have. Or actually, our one of our pain consultants, Glenn Williams, so he has a really cool podcast on pain, where he talks about anxiety medication for chronic pain, and that can be helpful. So things like amitriptyline and nortriptyline are quite commonly prescribed for people with chronic pain as well. So and it's interesting when you look at the pathways that are involved in pain perception and pain modulation in the body. The dopamine system is heavily involved, and the noradrenergic pathways are heavily involved as well. So people are kind of looking into maybe targeting those pathways as well for dealing with pain management. But yeah, it's it's a big issue. It's an ongoing issue, and people are still working out how to help it, because it can be really problematic.
We have a related question again from Anonymous. And they ask, is there a medication or a sort of family of medications that tend to be best for treating chronic pain?
Again, not a medical doctor, so I'd be hard pressed to answer that question. I would definitely refer you to Glenn Williams's podcast, because I'm sure he talks more about that. And there's a lot of research out there looking at pharmacological approaches to chronic pain. Again, it's really difficult to try and target specifically with medication because of the complexity of chronic pain. There's no like off switch for chronic pain. So using pharmacology to try and treat that is quite often not going to be, it's either not successful at all, or it will be minimally successful. And that's why we are trying to develop these pain programs that are looking at the social and the psychological treatments as well, and kind of using all of it together, kind of enmeshing all of it together has a much better effect. But generally medications for chronic pain are not super helpful. They can be quite helpful for some people, but generally if you've got chronic pain, it's not going to treat the whole picture. You need to look at yourself as a holistic being, and think about all those other things that are going on for you and how you can target some of those to help. And that's quite a hopeful thing, because medication doesn't work for everyone, and it's really actually kind of a positive thing that's like, oh, there are all these other things in my life that I can try and address to alleviate this experience and do better going forward.
Our next question comes from Igor, and he asks, is there a way to recognize that you actually have chronic pain that you need to do something about, and it's not just a normal amount of random pain?
Again, it's I think if it's persisting and it's affecting your quality of life, then it's probably worth doing something about. If you're noticing that it's having a really tricky impact on your life, or that it's ruining your life and it's starting to make your decisions for you, that's when you probably need to look at trying to do something about it, or asking for help, because it's getting to that point where, like I've said a few times, that metaphor of pain being in the driver's seat of your life, that's when it's really a problem, and we need to try and put pain in that backseat again. So if you're really noticing that it's really affecting things, affecting your quality of life, affecting your decisions that you're making, if you're not going out anymore, if it's affecting your work or affecting your ability to socialize or do the things that you want to do that you find important, it's definitely worth looking into and seeking help from a medical professional. Hopefully someone that really understands pain and chronic pain.
I was wondering, so you've spoken a couple of times about that measure of quality of life, and in your talk, it seemed to be that there were some ways of like measuring quality of life.
Mm-hmm.
I was wondering if you could elaborate on that a little bit, like what is a good quality of life?
So the measure that we use for young people is called the pediatric quality of life measure. So there are 4 domains. There's the physical domain, the emotional domain, the social domain, and the school domain. Well, school, and I think it's work in older adults or teenagers that are working. So it splits it up into those 4 different things, and we do measure those 4 things. They can be measured separately, but then you also get this total score. So we look at those different aspects of life, and some of them are more affected than others. Some people might be pretty okay physically, but their emotional well-being is really, really low. They're having really difficult mood issues, or it might just be that they have a lot of problems keeping up with their peers, or that other kids bully them, or it could be any manner of things. But usually no one's 100% in any of them, in just one of them, and also no one is 0% in just one of them. Whenever you do the questionnaire, you can see that every single area is affected. And I think that's really telling of how chronic pain affects us, because it's that whole picture of your life can be affected and targeted and helped.
Yeah. So it's more complex than sort of how much you're enjoying yourself. It's
Yeah.
things like how well you're able to engage with education
Yeah.
and
Yeah. Are you missing school? Are you finding it difficult to concentrate in school? How difficult is it to, take a shower by yourself or walk 100 meters or, um, yeah, how much of a problem do you have, um, having fun or enjoying things or, feeling happy or, there's, yeah, all sorts of different stuff. Yeah, I think there are, uh, 15 plus 8, 23 questions in total. So lots of different things.
our next question comes from Linda, and they ask, is there research about how your expectation of future pain affects your response? So, for example, if you're told your periods will be painful versus not expecting problems, will that impact how you experience menstrual cramps?
Um, yes, I think there is a lot of research about that. So Harriet has just messaged me. She's got a great TED talk for that. So it's called anticipatory pain. Um, so there's a TED talk called Why Things Hurt. I think it's by Lorimer Moseley, talking about like a snake bite versus a twig, and what you think it is can have a big impact on how much pain you're feeling. Um, so yes, I think there is research on this, and we were all kind of aware of it as well. Um, and it's that how much danger does this thing signal, for example, can have an effect on how much pain you feel. I mean, I notice it all the time, like thinking that, is it just a leaf that scratched me or is it an insect biting me? And that like it can feel super painful or not painful at all, depending on the context that it's in. Um, yeah, it's kind of like I guess it goes back to why we have pain in the first place, which I guess I didn't really actually talk about in my talk. Like the point of pain or the point of acute pain is that it's a protective mechanism, right? Like we experience pain because our brain wants to tell us that there's it's a danger signal, like there's something going on, there's damage happening, you need to do something about it. It's like an alert, right? And
Mm,
the issue with chronic pain is that, the danger might have gone away, but that alert is still flashing.
yeah.
And that's the issue. But yeah, that thing about the expectation of pain or the context of it changing how much pain you feel. I guess you can call it like a survival mechanism. So it kind of goes back to processing of the pain in the brain and how much threat we we see as being present in that situation. Um, yeah, and in terms of how much your expectation of future pain would affect your response, I mean that's kind of um, uh, addressed in when we're talking about pain catastrophizing as well. So if you are a person that anticipates future pain, or if you worry a lot about it constantly, and you're like, okay, it's always going to be this bad, or I'm going to have more pain in the future, that tendency to catastrophize and to expect that pain is going to happen again can be a risk factor for developing chronic pain or for it to continue. Um, so there is research around that. Yeah, and there's also the kind of thing of, what we're told and our memories influence how much threat we perceive from pain as well. So, uh, short answer, yes, there's research, and yes, it does affect you. And yeah,
Our next question is another anonymous one. And they ask, have there been any total success cases in chronic pain alleviation in your experience? And if so, can you elaborate on the progression and treatment in these cases? I
um,
suppose before answering that, I guess what would, like, do you talk in terms of like total success and what would that look like?
um, yeah. I mean, is it that you mean you've got rid of people's pain? Or have we got rid of people's pain? I mean, we can't. share any results that we've got at the moment because they're unpublished and it's still ongoing. Um, that's a hard question. I can't elaborate on progression of treatment in any cases that we have. Um, I mean, for some people, generally, chronic pain can go away, and then that's great for them. But for a lot of people, it's about living alongside the pain, and that's really what we emphasize in our program is learning to live alongside it and learning to take back control of your life and not letting pain make all your decisions. And we can say that, I mean, I can say that we do see young people learning to live alongside their pain, learning to live their life despite the amount of pain that they're feeling. And sometimes that does go along with a reduction in the amount of physical pain that they're reporting, so that, their average pain or their worst pain over the last week or whatever. We can see some a reduction in those numbers. Um, but yeah, I mean, our goal isn't necessarily to remove that pain. It's all about learning to manage it, um, and learning about how your pain impacts you, your whole self, and how to take back that control. Um, it depends on the person and their context and their life experiences and what they choose to make use of going forward. And sometimes it will have amazing, incredible effects, and but for a lot of people, it's not a magic wand, but it can still be super, super impactful and helpful. Um, it's also not always helpful to completely push pain away, which is why we base, as I said before, our program is a lot of it is based on the acceptance commitment therapy um, research. So that idea of acceptance that pain is necessary, it's a necessary part of our survival. There's a lot of research on there's a genetic mutation you can get that means that people don't feel the pain at all. And a lot of them tend to get horrible injuries or die quite early because you're not getting that alert signal, and that's not helpful. So we do need pain in our lives, and it is a useful thing. And getting rid of it isn't the right target. I mean, obviously, having chronic pain isn't ideal, but again, it's about managing it and learning to live alongside it rather than um, trying to remove it completely. We don't want to create false hope in people.
Sure. And I guess thinking about the way in which you measure quality of life, there's going to be potentially difficult choices to make there. So, like, for example, perhaps you could massively reduce your experience of pain by not going to school anymore. But is that ideal? Like, is that a good trade-off? I guess.
Yeah, exactly. Like, what does it mean to be cured? What does it mean to have a successful treatment? And for us, the idea of success is people going out there and living their lives and taking back control and going back to school and engaging with their friends and doing the things that they've always really wanted to do. Um, and that's great. We want to move away from avoidance because that leads to increasing fear, and we want to move towards the yeah the pain becoming smaller in its impact on your life rather than pain going away. One really cool analogy that one of our psychologists came up with, one of our young people found really, really helpful, was the life bucket and the pain bucket. You want to take stuff out of the pain bucket and put it in your life bucket. So all of the things that pain is controlling and that you're putting a lot of attention into, we'll try and start removing some of that and put it into your life bucket so that you're putting more energy into living your life and enjoying the things that you want to enjoy.
Yeah. Our next question comes from Monica,
Mhm.
and they ask, you mentioned some families decline the programme as they can't afford to stay or buy food in London. Is there no possibility of means assessed funding for this?
So we do have now food vouchers for families. So if they want to, we provide them lunch vouchers basically so that they can go to the canteen and get a meal every single day that they're on the program. And we also provide funding. We provide hotel rooms basically for families that are coming that can't commute in every single day. But yeah, it's still an issue. Like these families are still oh yeah, Harriet's just reminded me we're trialing providing breakfast as well, so they can come when they get in. They can get in at a little bit earlier, like 9 o'clock. So usually the program starts at 9:30, but they can come in from 9 o'clock, and we can provide cereal and milk and tea and coffee and all that kind of stuff. Not sure how long that can continue for because we obviously have a limited amount of funding. NHS funding in general is, yeah, as everyone knows, is really hard. It's a really hard situation. And definitely part of the research that we're doing is to record which families are declining, why are they declining, if they're declining because of uh, you know financial reasons. That's really important to know, and we can put all of that data together and present that to the powers that be and say, hey, look, there are some families that are not able to access our treatment because of these financial barriers, and that's really sad and that's not okay. And that's just kind of propagating that those social divides or the socioeconomic divides. And unfortunately chronic pain is always going to be more prevalent in communities of lower SES communities, and we really need to try and find ways of improving access for those communities. So it's really important that we record that, and yeah, hopefully we can end up getting more funding for families like that.
Are there any charities or anything like that that maybe some of our viewers or listeners could potentially donate to help with that side of things?
Ah, good question. I don't know. um uh Gosh, charity, I guess,
Yeah,
is one.
Great Ormond Street Hospital charity.
Yes.
Yeah,
Yeah. Um, yeah. So our
yeah,
funding kind of comes through them. I mean, it's donor funded for the program, but it comes through the Gosh charity. So, um, yeah, and they're always looking for donations and help. So,
yeah.
yeah, probably the most straightforward one.
And that issue of accommodation when you have a sick child is not going to be specific to children with chronic pain. It'll be kids in all different
Yeah.
wards in across the hospital, and like
Yeah.
finding places for the family to sleep is
Yeah.
not cheap. So yeah,
Yeah. 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 It's tough, and and it and it depends on the family makeup as well. Like uh, it's not like all chronic pain kids are single children. There's a whole family unit that is affected, and you've got the parent and the child coming, and we've got one hotel room to give them. But what happens to if they're a single parent, what happens to the other child at home? Who's looking after them? And how does all that work? Yeah, it can be really tricky and complicated. And um, yeah, we're recording all of those things and trying to, as we move forward, hopefully it will get easier to manage those. But yeah, it is all part of it, and it can be really difficult.
so we have another anonymous question. And they ask, so how much of this research will likely transfer to treatments in adults?
So there are already intensive interdisciplinary pain programs for adults that are running in the UK as well as overseas as well, and they are doing their own research as far as I know. Um, a lot more there's actually a lot more chronic pain research on adults than in young people and teenagers. Um, and that's why we're doing our study is because we need more research on how well this works for young people and for teenagers especially. um but yeah, it's already established in adults, and yeah, we want to do it in young people to try and hopefully the younger you address these issues, the better things are going on. Yeah, teenagers become adults, so we will find out as they age as well. We've got people coming in when they're 16, 17, and when we follow them up at 5 years time, they'll be adults, and seeing how they're getting on at that stage will give us some adult research.
Okay. We have one final question and then we will let you go. And this one comes from Monica. And they ask, Biased question, as an art
Mhm.
psychotherapy trainee, has your team considered adding art therapy to the program, or might you consider it in the future?
Yeah, I love that question because I love art and I love art therapy, and we've definitely talked about it a lot as a team. I mean, as part of our sessions, we have sessions on exploring what things like hobbies and things that they might be interested in. So we'll take people out into the park and we'll do photography or you know playing with lights, or we'll get a bunch of. We had a really great donation from the play team at Gosh of like loads of art supplies and canvases, and I had a really great couple of sessions where I was just like, okay, let's just sit down and paint and use whatever colors you want and get messy. And that I mean, there's a lot of research showing how helpful art therapy can be for chronic pain. Well, there's a bit of research on it. I'd love to do more because I think it can be really helpful. One thing with our program is that it's jam packed full of stuff, right? Like we're fitting of a lot of sessions into the program and looking at lots of different things. And with when you're going quite deep with art therapy and chronic pain, you have to be quite careful in terms of continuity and holding those, what comes out of um, these sessions um, where people are talking about their chronic pain and putting it onto a page or whatever they're creating. You have to be really mindful about holding that and making sure that it's not just like, you're going into all of this deep stuff and you're bringing out some really intense feelings, and then it's like, oh, end of session, okay, off you go, see you tomorrow, and then we're going to talk about something completely different for the rest of the week. um, so there's a balance between using really awesome things like art therapy, but also making sure that you're not pushing people really deep and kind of leaving them there. Like there has to be, you have to think really carefully and plan it really carefully. So at the moment, the kind of art therapy that we're doing is quite broad, and it's kind of like, in a way it's shallow. It's kind of more about, okay, let's get messy and play. And it's also a really great way to learn how to communicate in a different way. So, especially for neurodiverse individuals, sometimes using words can be really difficult. So, putting their thoughts or their feelings on on a canvas can be like a awesome release for them, or just a really cool way of communicating how they're feeling to other people. And a lot of, we have a graduation at the end of every 3-week program where the kids will kind of do a really cool presentation. And a lot of them are like, I'm amazed at how arty and creative these young people are. Like some of them are, a lot of them are incredible artists. And I'm like, wow, this is so cool. And they just kind of naturally do that anyway. But yeah, you do have to be quite mindful about not just throwing things like art therapy in. Like it has to be really carefully considered. But definitely, it can be really helpful and really useful. And I hope that we can keep doing more of it in the future. The team in Helsinki, so there's a pain management program for young people in Helsinki in Finland, and they have music therapy. And they have a whole big music therapy team that they use a lot, which is so fun and so cool. And they have some research available that I'm not sure if it's published or not. I did have a couple of slides on, if we had time. I was going to talk about virtual reality and the effects of music therapy for people with chronic pain. So yes, there are some really great effects, even just in terms of reduction in pain levels with art therapy, music therapy. So yes, definitely considering it and using a bit of it, but we're using it as mindfully as we can.
Well, we might have to invite you back for another talk so that we can hear more about art therapy and virtual reality and the ways in which that can help with chronic pain treatment. Like that, I think that in itself would also be an amazing talk. Um, but yeah, thank you so much for your talk tonight. It's been really interesting, and it's like incredibly worthwhile work that you're doing. And thank you very much for sharing it with us.
Thank you for
And
having me.
And so that's it for tonight. We will be back again on the fourth Thursday of next month with another talk, which we are yet to announce, but keep an eye on our socials and on our website to find out details. But we will be back again on the fourth Thursday at 7 p.m. UK time. And if you would like to carry on spending time with us tonight, we're about to open our virtual Zoom pub, the Lock-ins Razor, and you can find out how to come into there via our website, sitp.online, and there'll be links there. And I'm sure there'll be links in the chat of how to find us on Zoom. And thank you very much for tuning in, and hopefully we'll see you next month. Thank you. Bye.